We've covered a lot of ground in this series on HRT. We took apart the Women's Health Initiative and showed why a 20-year-old study in 63-year-old women doesn't tell us what hormone therapy looks like for a 52-year-old woman sitting in a doctor's office today. We looked at the reanalysis data, the various studies, the timing hypothesis. We talked about estradiol, micronized progesterone, and testosterone. 3 hormones with meaningful evidence behind them that are fundamentally different than what the WHI tested and the results they came up with. Now, I'll answer the question that all of that science was building toward. What does it actually look like to get this evaluated and done properly by your doctor? Because information is only valuable if it leads somewhere, and for most of the women watching this series, the place it should lead is to the real clinical conversation with a physician who takes the time to understand you as an individual, runs the right tests, asks the right questions, and creates a protocol built around your specific biology and your specific goals. Today, I'm walking you through exactly how that process works in my practice, step by step. What we look at before we ever prescribe anything, how we decide what to use and at what dose, and what ongoing monitoring looks like so that we're not just starting a protocol, we're going to manage it correctly over time. Hello again. I'm Dr. Greg Oliver. Let's finish this series on hormone replacement therapy for women. Before we run a single lab or write a single prescription, we take a thorough history, because hormone optimization is not a symptom and a prescription transaction. It requires context. So, we want you to understand your full symptom picture, not just hot flashes, but sleep quality, thinking and cognitive function, mood, energy, libido, joint and muscle symptoms, weight changes, urogenital symptoms, all of it, because of it can be hormonally driven, and all of it informs us what we should do. So we look at your personal medical history, current and past conditions, surgical history, including whether you have a uterus or had a hysterectomy, whether you've had any history of blood clots, cardiovascular events, or liver disease. We look at your current medications and supplements, any history of hormone-sensitive cancers. We look at your family history, things like breast cancer, heart or cardiovascular disease, osteoporosis, thyroid disease, dementia. These aren't disqualifying in most cases from taking hormone, but they shape how we think about risk and which hormones and delivery methods make the most sense for you. We look at lifestyle, things like smoking status, alcohol use, exercise habits, diet patterns, sleep. Not to lecture, to be precise. Hormones don't exist in a vacuum. A woman who smokes, for example, has a different heart and cardiovascular risk profile that bears on which delivery method of estrogen will be the safest for her. Now, all of that happens before we look at a single lab value, because labs without context are just numbers. Labs in context of a thorough history become a full clinical picture. The baseline blood panel serves 2 purposes. First, it establishes where your hormone levels are right now, before we touch anything. Second, it screens for any metabolic, thyroid, and other conditions that affect how we interpret your symptoms and how we design your specific protocol and treatment plan. On the hormone side, we're looking at estradiol. We look at your serum estrogen level, along with FSH and LH, which are the pituitary hormones that rise as the ovaries produce less estrogen. Elevated FSH with a low estradiol is one of the clearest markers of being in menopause. We're also looking at progesterone. We're looking at total and free testosterone, sometimes sex-binding hormone, which is the protein that binds testosterone and estradiol and affects how much of each hormone is going to be active in your body. So we take a look at all of these tests. Sometimes we often include DHEAS, the adrenal hormone that is a precursor to both estrogen and testosterone. And we look at morning cortisol, which gives us a window into your adrenal function and how stress physiology may be interacting with your hormonal picture. So we look at all those hormones, not just individual ones. On the metabolic side, we run a complete metabolic panel, a fasting lipid panel, fasting glucose and hemoglobin A1C for insulin resistance screening, and a complete blood counter CBC. These aren't afterthoughts, they're essential context. A woman who is insulin resistant, for example, may have a different hormonal metabolism than someone who isn't. A woman with already elevated heart and cardiovascular risk markers changes the risk-benefit calculation for oral versus transdermal estrogen. So all these things are important in making those decisions. We always run a comprehensive thyroid panel. This is non-negotiable because thyroid dysfunction mimics almost every menopausal symptom: fatigue, weight gain, brain fog, mood changes, cold intolerance, and hair loss. Before we attribute any of these systems to an estrogen deficiency, we need to know your thyroid is working properly. Many women who come to us have been told they're simply menopausal, and the significant symptoms of the thyroid issue were missed completely. Beyond these labs, there are 3 imaging studies that are foundational to proper hormone optimization baseline. The first is we want our patient to have had a current mammogram. Okay, that's important. Hormone therapy, in some cases, can increase breast tissue density, which can affect mammogram interpretation. Having a pre-treatment mammogram establishes your individual baseline breast density and tissue appearance. So, if anything changes on subsequent imaging, we're comparing to your own prior films, not some average in the population. Current mammography recommendations for women at average risk call for an annual screening starting at 40. If you're starting hormone therapy, having a current clean mammogram before you start is simply being and treating good medicine. The next is to see a DEXA scan. This is a dual energy X-ray absorptometry, which measures bone mineral density. Having had this scan before can be important in starting hormone therapy. Bone loss accelerates dramatically in the first few years after menopause, and many women don't know where they're starting from. So a baseline DEXA scan tells us whether you're entering this phase of life with healthy bone density, or maybe early osteopenia, or with more established bone loss that affects both your fracture risk and the urgency of our approach to bone protective therapy. Estradiol is one of the most effective bone protective agents available, and knowing your baseline makes the benefit of treatment measurable. So we check to see if women have had a DEXA scan. If not, we recommend they get one. The third, for women who have a uterus and will be taking estrogen, is a pelvic ultrasound to assess endometrial thickness and uterine health. This establishes a baseline against which any future changes can be compared, and screens for any pre-existing structural issues we need to know about before beginning estrogen therapy. So these are not some bureaucratic checkbox we do on some form. They are clinical foundation that makes individual hormone therapy medically responsible. And they're part of what distinguishes a supervised in-person care from telehealth prescription issued after filling out a questionnaire online. One of the most important things I can do in a video about hormone therapy is be honest about when it is not the right choice. Because proper evaluation includes screening for contraindications, and not every woman who wants hormone therapy is a candidate for all forms of it. So this is important. The absolute contraindications, which are the situations where using hormone therapy is definitively off the table, are as follows. First, active or recent history of breast cancer or any other estrogen-sensitive cancer. This is not a judgment call. Estrogen can stimulate the growth of hormone receptor positive tumors. A history of breast cancer is a hard stop for systemic estrogen therapy in almost every case. Second, unexplained vaginal bleeding that has not been evaluated. Before starting estrogen, we need to understand why there's bleeding. estrogen given to a woman with undiagnosed endometrial cancer would be quite dangerous. Number 3, active or recent venous thromboembolism or blood clots, or a known clotting disorder such as factor V Leiden or antiphospholipid syndrome. Oral estrogen increases blood clotting risk. Even with transdermal delivery, which carries a much lower risk, a personal history of clotting events requires careful, specialist-level evaluation before any hormone therapy is initiated. Next, active cardiovascular disease, which would be a recent heart attack or stroke. This is particularly important in the context of the WHI. The harm signals for cardiovascular events were contraindicated in older women with pre-existing cardiovascular disease. So, starting estrogen in someone with active coronary artery disease or a recent cardiac event would not be appropriate. Any active liver disease with abnormal liver function. Estrogen is metabolized by the liver, and active liver dysfunction significantly changes the metabolism and the risk profile. Now, I want to be equally clear about what is not a contraindication or a reason to take estrogen. A family history of breast cancer in the absence of a personal history is not an absolute contraindication. It's a risk factor that informs our conversation and our monitoring, but it doesn't automatically exclude a woman from hormone therapy. Cervical cancer, most ovarian cancers, and certain other gynecological cancers are also not absolute contraindications. Fibrocystic breast changes, controlled hypertension, and many other common conditions are not contraindications. They are factors that inform dosing and delivery choices. So the point is, proper screening catches the women who should not be on hormone therapy and protects them. And it accurately clears the women who can be on it safely, which is most healthy women under age 60 who are within 10 years of menopause onset. Now, once this history is complete, the labs are back, any imaging is reviewed, and contraindications are cleared, we build a protocol of therapy. And I want to emphasize, we build it specifically for you, not for a demographic, not for a standard order set, for you. For most women, we start with estradiol, typically transdermal, because of the more favorable clotting and stroke risk profile we discussed in video 3. We start at the lowest dose that is likely to be effective, and then we adjust it from there. For women with a uterus, micronized progesterone is added, but can also be added to women without a uterus to gain the added benefits of this particular hormone. If testosterone is indicated, and for many women it is, we discuss delivery options. For many of our patients, we use a topical testosterone cream dosed at physiologic levels appropriate for women. For women who prefer the convenience of not having a daily topical routine, pellet therapy is an option where we insert pellets under the skin. And more recently, appropriate dose administration of testosterone can be self-injected at home once a week with a very small syringe. We teach this method routinely, and many women prefer it. For the first 90 days, we typically schedule a follow-up at the 6 to 8 week mark. By that point, we expect to see early symptom response. We talk about what's been improved, what hasn't improved, whether there are any side effects or tolerability issues. And we repeat the relevant labs to see where levels have landed, so we know if we're on the right track to treating it properly. This follow-up appointment is not optional. It's where we find out whether your estradiol level is actually in the therapeutic range, because absorption varies by individual, and a standard dose patch does not produce a standard result in every single woman's body. It's where we catch early issues before they become problems, and it's where we make the dosing adjustments that fine-tune the protocol from working to being optimized. And that's critical. Hormone optimization is not a one-time prescription. It's an ongoing clinical relationship. And the difference between those two things for patient outcomes is quite significant. Now, after the initial adjustment phase, ongoing monitoring follows a defined schedule. And here's what that looks like in my private practice. Labs are typically repeated every 6 months in the first year. We get an estradiol, testosterone, and other metabolic markers, and annually thereafter once levels are stable and the protocol is optimized. We're looking for several things. Number one, that hormone levels remain in the therapeutic range. We also look that metabolic markers haven't drifted in any concerning direction, that liver function remains normal, and that lipid panels are moving in the right direction. So these follow-up tests are critical and important. Mammograms continue on their recommended annual schedule. If hormone therapy increases breast density on imaging, which it can do in some women, we discuss the implications for mammogram sensitivity and whether any additional imaging such as ultrasound or MRI might be warranted for that particular woman. So checking these is, again, important. DEXA scans are typically recommended every 2 years, and most people's primary care may get those depending on baseline bone density and individual risk factors. One of the most satisfying conversations in my practice is showing a patient whose DEXA 2 years in has stabilized or improved because their trajectory of untreated postmenopausal bone loss is not an upward direction. If it's untreated, it's a downward direction. For women with a uterus on estrogen therapy, we monitor endometrial health. Any new or unexplained vaginal bleeding on therapy triggers evaluation. Not panic, but evaluation, because it may simply reflect the therapy, or it may be something that needs to be looked at a little bit more closely. Clinical visits, annual at minimum, once stable, are not just for labs. They're for the full picture conversation. Things like, how are you sleeping? How's your energy level and your cognition or thinking? How's your libido responded? How's your weight doing? Have any new health conditions emerged that affect our adjustment or calculations? Has your family history of breast or cardiovascular disease changed with a new diagnosis in close relatives? So this is the difference between a maintenance prescription and an active clinical relationship. The monitoring is what makes it safe. The ongoing conversation is what makes it most effective treatment we can give. So I want to speak directly to a question I get often. What's the difference between getting hormone therapy from me or getting it from a telehealth service? And I'm going to answer this as honestly as I can, because the answer is not that telehealth is bad. For many types of care, telehealth can be excellent. For simple, straightforward medical needs with low complexity and low stakes, telehealth can be efficient and quite appropriate. And I've done telehealth with many of those patients. But hormone optimization for perimenopausal and postmenopausal women is not a low complexity, low stakes undertaking. It requires individualized evaluation that is difficult to do through a questionnaire. It may require imaging. You cannot do a mammogram or a DEXA scan through a video call. It requires physical exam findings that give you information a self-reported symptom list simply cannot. And it requires ongoing monitoring with clinical judgment to interpret results in the context of that specific woman's history, not a population standard, which sometimes happens online. What I've seen in practice and what concerns me about some telehealth HRT services is a pattern of standard protocols prescribed rapidly to women who may not have had a complete contraindication screen, who don't have a current mammogram on file, whose bone density is unknown, and who have no clear plan for follow-up or monitoring. That is not hormone optimization, that is hormone prescribing. Now, to be fair, some women who've used telehealth HRT services have gotten reasonably good care. The providers at many of these services are genuinely trying to help. But there are structural limitations of telehealth format. Time constraints, the inability to examine, the absence of coordinated imaging or testing make it genuinely difficult to deliver the depth of evaluation that this particular clinical area requires. So, if you are currently on hormone therapy from a telehealth provider and you're wondering whether you're getting what you need, That question is worth exploring. So, take your records to an in-person consultation. Have the conversation. Make sure the person managing your hormones knows and understands your full history and is monitoring you appropriately. Now, if you've watched all 4 videos in this series, you now understand more about the real science of female hormone optimization than most of the patients who walk through my door, and honestly, more than some of the physicians who told them there was nothing that could be done. You know why the WHI scared a generation of women off hormone therapy, and why that fear was based on misapplication of the findings from a fundamentally misdesigned and flawed study for that purpose. You know about the timing hypothesis and why starting hormones in the years around menopause is a fundamentally different clinical situation than starting them in a 63-year-old female. You know that estradiol, micronized progesterone, and testosterone are not the same drugs that were tested in this major Women's Health Initiative study. And you know what a proper evaluation and monitoring protocol looks like. That knowledge is yours to use. Use it to have a better conversation with your own physician. Use it to ask better questions. Use it to push back if you've been told the science is settled and hormone therapy is simply too dangerous, because the science is not settled in the direction they may have been taught. And the conversation has definitely changed in the last 20 years. To every woman watching this series who's been struggling with sleep, with weight gain, with energy levels that drop, with cognitive fog, with a body that stopped responding the way it used to, you have not failed. Your hormones changed. And that is something that medicine can address properly, safely, for most of you. So don't accept unnecessary suffering as the cost of getting older. You deserve much, much better than that. I'm Dr. Greg Oliver. Thank you for watching the HRT Truth Series. I hope it serves you well. I look forward to seeing you in our next video, which can help you to strengthen psychologic power for long-term weight loss and weight loss maintenance. So long for now.